Dr. Amit and the organizers for giving me this opportunity. It is crucial to know the proper access to elbow to treat a particular fracture so as to gain easy access towards the lesion and ease the fixation. There are various options available such as posterior approach, lateral, medial, anterior, combined and modifications of each approach. Amongst the posterior approach, there are a variety of modifications like triceps splitting described by Campbell, triceps reflecting, triceps sparing, triceps reflecting with osteocutaneous flap, and olecranon osteotomy. So, triceps splitting approach as described by Campbell is very popular and everybody knows how to use it for fixation of distal humeral fractures. As compared with our triceps aponeurosis turn-down approach. The paratricipital approach or triceps sparing approach is a very good approach when the fracture extends from distal articular into shaft of the humerus, and via this approach we can literally expose the entire shaft posteriorly. Medially, the interval lies between the cubital tunnel. It goes up to the medial intramuscular septum and lower down to the first motor branch of the ulnar node. And laterally, the plane lies between anconeus and the triceps. So, radial nerve approach very well with this approach right from the lateral intramuscular septum till the radial groove, and we can pass the plate underneath the radial nerve very safely and securely. Olecranon osteotomy was first described by McCausland. It was a transverse osteotomy described for treating stiff elbows. Later on, the design was modified to chevron type, which gives approximately 57% of the exposure of the distal humeral articular surface. There is an extra-articular osteotomy advised by Muller, which is oblique osteotomy, which avoids articular fixation. Mayo Clinic modified this olecranon osteotomy by keeping the origin of the anconeus intact with the triceps. The anconeus is elevated from its ulnar bed and reflected along with the triceps with the proximal osteotomy fragment to give a nice exposure of distal humeral articular surface. Almost every fracture is fixed with this approach. Brian Murray advocated posteromedial exposure, especially for doing total elbow replacements. Incision is taken slightly medial to the olecranon. It is a longitudinal incision, and the entire triceps along with its insertion is reflected from medial to lateral side along with the anconeus till the lateral epicondyle, so as to get a nice exposure of distal humeral articular surface as well as proximal radius ulna, which is required for total elbow replacement. And then at the end, the triceps is sutured back to the olecranon with a cruciform suture technique. Lateral approach is a very versatile approach. Cockers described interval between anconeus and ECU to treat radial head problems. This approach can be extended proximally to treat capitulum fractures as well. There is a collateral sparing approach described by Kaplan, which uses interval between extensor digitorum communis and ECRL. This spares the LUCL and goes through the radial annular ligament, and this can be extended to supracondylar ridge to fix the coronal shear fractures as well. So with Cocker's approach, we can treat terrible triad injuries, capitulum fractures, and so on. This can be extended proximally to supracondylar ridge, and we can treat floating elbows with this approach. We can treat lateral condylar fractures, terrible triad. We can treat stiff elbows, neglected dislocations. The collateral preserving approach, as described earlier, uses the interval anterior to the lateral LUCL, and it is mainly used for treating mild to moderate contractures of elbow. Another approach is described as a lateral epicondyle osteotomy approach. and mainly used to treat difficult fractures of the capitulum and trochlea. Another approach is Boyd's approach, which uses posterolateral exposure, and it is useful for all proximal ulnar fractures, including Monteggia fractures, and gives good access to proximal radioulnar joint as well. Coming to medial approach, mainly used for stiff elbow release, partial elbow release, for repairing MCL and coronoid fractures. For partial elbow release, the dissection is kept anterior to the anterior band of MCL. And for treating coronoid fractures, the FCU split approach is used. We can reach sublime tubercle by lifting the, transposing the ulnar nerve anteriorly and retracting the FCU part laterally. Another approach is described by Hotchkiss, which keeps the FCU origin to the medial epicondyle intact, and only the pronator teres with other flexors is reflected from supracondylar ridge, and it is reflected, and then the anterior capsule is opened. So we can directly fix the coronoid fractures or coronal shear fractures of distal humerus via this medial over the top approach. And lastly comes the anterior approach, not very commonly used, reserved for treating neurovascular problems. The tendon of biceps with its aponeurosis forms the landmark or lighthouse, and keeping lateral to this tendon, there is a plane between brachialis and brachioradialis, which gives exposure, excellent exposures to radial nerve. By retracting radial nerve along with the supinator, we can treat anterior fracture fragments of radial head through this approach. Retracting the biceps tendon laterally and brachialis medially, we can directly go to anterior capsule and treat anterior coronoid fractures or remove myositis mass from brachialis muscle. Similarly, we can retract the brachialis medially and release the pronator teres to release the compression neuropathy of median nerve and explore the brachiolatry as well. So through this approach, we can treat biceps tendon rupture, myositis mass excision, and coronoid fracture fixation with ease. Now coming to anteromedial approach, which is required for brachial artery exploration and median nerve exploration. So this goes medially, anteromedially, and in this way, between the triceps and the brachialis, we can find brachial artery and median nerve, which can be repaired in this manner. So in conclusion, the most appropriate surgical approach should have the following qualities. It should have the potential to be extended proximally as well as distally. It should allow adequate visualization. It should be safe enough and preserve the normal anatomy. It should follow the natural tissue planes and also allow careful hemostasis and closure. Thank you.